Hi, Dr. Gullberg here, continuing our infectious disease series. Today we're talking about primary bacteremia, which is basically bacteremias that are related to central lines. There's a big problem in our nosocomial infections, our healthcare associated infections. We call them CLABSIs. Not a high percentage of our nosocomial infections, but when they occur, you got to know what to do with them. So again, this is bacteremia related to a access IV line. We have systems in place to try to prevent these. Thankfully, they're very rare, but there are basically four types of central line infections that I want you to be aware of. And again, I don't care if the central line is related to dialysis catheter like a permacath, whether it's a chemotherapy port, whether it's a Groshung catheter, whether it's a IJ catheter, whether it's a PICC line that's been placed for long-term access. So number one is the transient bacteremia. This is somebody that's got a positive blood culture, but they're not that sick really at all. No white count, no high fever, maybe a little chill. Don't pull the line initially in these patients. Or the device, unless it's a gram-negative rot. If it's staph, MRSA or MISA, or if it's yeast, then you have really no choice, but you need to pull it likely. The second common cause of infection is what we call an exit site infection. This is where there's maybe some mild purulent drainage at the exit site. We can generally treat these locally and with oral antibiotic therapy. Usually don't have to get rid of the access catheter. The third type of infection is more serious. This is a tunnel infection. This is where there's redness, warmth, tenderness on palpation, right under the skin. This is a must for pulling out the catheter. And then IV antibiotics should certainly be utilized in this setting. The fourth infection is called a septic phlebitis. This is less common, but very serious. This is when septic pulmonary emboli can occur, and of course when the vein or even the central, the larger vein, the subclavian vein, might become infected with clots as well that become infected. It's a serious complication where the line obviously must come out. Remember, in general, if only 1 out of 2 blood cultures are positive, growing a coag-negative staphylococci, these are generally going to be what we call pseudobacteremias. And the other thing that's helpful for line infections is when we do pull a line, we should culture the catheter tip, see if it's the source of the infection. If it's rolled out on properly in the microbiology lab, and there's greater than 1,000 CFUs from that catheter tip, likely it's the source of bacteremia. Otherwise, sometimes these lines can be actually seeded from a distant site. So that's a nice summary of central line infections. Hopefully that helps. Dr. Gullberg signing off.